right, good morning, everyone. Thank you for having me. Let's jump right into the case. All right, so we have a 61-year-old male who presented to the ED with his wife after multiple falls at home related to abnormal movements occurring several times an hour. The abnormal movements started 2 months previously and progressively increased in frequency and intensity, resulting in frequent falls as well as loss of independent function of ADLs. His wife also noticed a progressive cognitive decline. Socially, he's a truck driver with occasional tobacco use, denied drug or alcohol use, and family history was notable for...
You seem to be going in and out, at least for me. It seems like we can hear parts of it and then it goes out.
Let me...
Just try speaking a little louder, Heatherlyn.
Okay.
It'll be fine.
Okay.
Just keep going.
Okay. I can also switch this in. Sorry, guys.
Of course, when we checked earlier, it was fine. Is that any better?
Oh, that's much better, much better.
Wonderful. Let's try that then. Okay. Well, we basically got the case there. Let's move right along. Okay, so this is a video of the movements. So watch his left arm, left face. So he's having faciobrachial dystonic seizures. Our patient was having these almost every 10 minutes or so. This guy's going to do it one more time just so you can see it. So keep your eyes on the left arm and left side of his face. Okay, so the patient states he was awake and alert during the episodes. Previous workup with an outside neurologist included MRI with and without, MRA, 2 lumbar punctures, an extensive serum workup, and a prolonged EEG, all of which was unrevealing. He was told he had seizures and put on Briviact, Valproa XDR, and clonazepam. On exam, he was oriented to self with otherwise fluctuating mentation, dysarthria, frequent faciobrachial dystonic movements bilaterally, and could ambulate with assistance. His exam was otherwise normal. His workup included discontinuing his AEDs, a prolonged EEG, which looked normal during the events, CSF, MRI brain with and without, and a CT chest, abdomen, pelvis, all of which was unrevealing. His workup was notable for serum autoimmune encephalitis panel, which was positive for LGI1 antibodies. This falls under the category of a voltage-gated potassium channel antibody disorder. Of note, his CSF autoimmune encephalitis panel was negative. LGI1 antibodies are more sensitive in serum testing. LGI stands for leucine-rich glioma inactivated 1 and is a protein that functions as a ligand for ADAM22 and ADAM23 protein. It's an autoimmune encephalitis, and 5 to 10% of cases are associated with cancer. The most commonly associated tumor is a thymoma. Most common signs and symptoms of LGI1 encephalitis include faciobrachial dystonic seizures, which have a poor response to most AEDs. However, some studies have shown these seizures respond well to carbamazepine. Other symptoms include memory and cognitive deficits, hyponatremia, and REM sleep behavior disorders. The treatment for our patient included 3 days of high-dose IV steroids, 5 treatments of plasmapheresis, and he was discharged on a steroid taper, oxcarbazepine, and clonazepam. The plan for long-term treatment was regular infusions of rituximab. On discharge, his exam was markedly improved. He was ANO times 3, he was no longer dysarthric, ambulating independently, and only having occasional brachial movements that were significantly decreased in frequency and intensity. So great job, team, in getting the correct diagnosis and treatment for this patient, and thank you all for listening.
Wonderful presentation. And an interesting case, Heatherlyn. So just to say it one more time, at 9:30, we're going to have our departmental group photo, and there will be opportunities for people who need photos for the website and whatever right after that. Just email Will. The CME again is on the chat, and I'll put it in there again. And to introduce our grand round speaker today, I'm going to throw it to Dr. Noreen Bukhari-Parlakturk.
Thank you.
Noreen, it's all yours.
Thank you. So it's my pleasure to introduce Dr. Stephen Frucht. He comes to us from NYU Langone, where he serves as the director of the Movement Disorders Division. I actually met him when I was a neurology resident at Mount Sinai. So we used to call him a man of many talents, and he actually was awarded that from our resident class. It was part because he's an excellent clinician, educator, and mentor. So as residents, whenever we had a difficult case, we actually presented to him on Morning Report. He's also published prolifically with over 10,000 citations on Google Scholars to date on all aspects of movement disorders. He's actually most well known for his work on musicians' dystonia, and in fact, he received the Leadership Award from Dystonia Foundation for his work on musicians' dystonia. Today, he will actually be giving 2 talks, first at Grand Rounds right now, and then second at the noon time for the Dystonia Monthly Conference. So feel free to join us for that as well. I'll hand it over to Dr. Frucht for his talk now.
Great. Well, thank you so much, Noreen, for that very kind introduction. It's very nice to be here with everyone. Can everyone see the screen okay?
Yep.
Okay, great. So we're going to spend the next few minutes talking about a disorder that I've been fascinated with for 30 years, and many people here are familiar with this entity of focal task-specific dystonia and what it can tell us about the nervous system, and in particular the way the motor system is organized. So it's no secret these have been difficult times for everyone, and our offices at NYU are on 41st Street and between 2nd and 3rd. I take the bus every morning, goes down 5th Avenue and lets you off in front of the New York Public Library with the 2 big lions out front. And there's a walk down 41st Street in which prominent quotes from the last 200 years from major books are in the sidewalk. And this is one of them from The Plague, which was very apropos walking into work for the last year, especially when New York was deserted. So what is dystonia? This is a review for many of you, but the late David Marsden really nailed it when he said it's both a symptom, a sign, and a diagnosis. So the best definition for me still is Stan Fahn's definition, which is that it's a hyperkinetic movement disorder characterized by sustained muscle contractions that cause twisting and repetitive movements or abnormal posture. So one can talk of the symptom, what the patient experiences, the sign that we see, and also the underlying diagnosis, which has a very broad list of etiologies. You'll see examples of these if you tune into the noon lecture when I'll go through some of the more obscure ones. So these are some examples. This is a young girl with DYT1 dystonia of the left foot. And you can see that that foot is abnormally flexing down as she walks. This is another young woman with DYT1 that's causing abnormal movements of her right arm, particularly when she types. She's learned how to type 40 words per second just using her left hand, which is quite something. These are 2 brothers with Lubag DYT3. The one on the right has cervical dystonia, and the one on the left has Parkinsonism. This young girl has DYT12, and she was adopted from China, having these episodes that were thought to be seizures. In fact, they were oculogyric crises, which paradoxically responded to levodopa. Here she is when she's treated. So you get a sense of the broad spectrum of this condition. This is a woman who I've followed for over 20 years, and she had a delayed onset hemidystonia affecting her left arm after a childhood stroke at the age of 8. And she's adapted to this. She has 2 kids and works full time. But you see this sustained posturing of that left hand. It's present at both rest with action and also with intention. All right.
December, I was cheering for the Giants. I pulled something here. It got better for a few days.
So this woman has focal task specific dystonia, jaw opening dystonia. You're going to see some examples here. She's a very dramatic example of this. I'll show once more again because she's also very.
December, I was cheering for the Giants. I was. I pulled something here. It got better for a few days, and I did it again 2 weeks later.
This is good.
And when I eat, I sound great.
You see that she's got a sensory trick there. Sorry about that. Holding the pipette between her teeth there. She also is able to eat with no problem. This gentleman has praying dystonia.
But it's kind of like squeezing.
It's worse.
Yes, it's squeezing. Okay, doctor, I'll tell you, it's like when I'm telling you these things now, it's like, nothing happened.
So this can be quite a bizarre condition. Here we have a young man, very high-level ping pong player who has dystonia of the right arm that deducts just with when he is playing ping pong. This is totally involuntary. He cannot control it. He can't inhibit it here. And this can be even more bizarre. This is a man you might think is functional, but in fact is not. He has a dystonia of that right leg only triggered by going downstairs. That leg will come up almost into a triple flexion response, but he's able to climb stairs just fine. So you might think, how is this even possible? Such a bizarre condition. The two main themes that we don't have time to talk about, the thousands and thousands of papers on the mechanisms of dystonia. This is work that I know Noreen is pursuing actively. But the two main themes are that dystonia is really a network disorder. We no longer think of strict localization within the nervous system of dystonia originating from the putamen or originating from the thalamus, but it's this complex interplay of the connections of the thalamus to both sensory and then to the complex motor networks, their connections to the basal ganglia, and the increasingly recognized role of the cerebellum as producing these dystonic movements. The other important point is the idea of center surround inhibition that John Mink and Mark Hallett put forth in the mid-90s, where probably at the level of the basal ganglia itself, the wanted motor programs are allowed and the unwanted motor programs are inhibited. And when there's a problem in that selection, one gets this overactivation of various muscle groups.
It was one of the great mysteries of modern music. Leon Fleischer, an internationally renowned concert pianist, suddenly lost his ability to play. But in 1965,
So Leon developed focal task specific dystonia at the age of 36, and that more or less ended his two-handed playing career for 35 years. This is Yehudi Menuhin, arguably one of the great prodigies who's ever lived. And here he is in the mid-40s playing in California with exquisite virtuosity. But he developed bow arm dystonia in the late 1950s, and you're going to see it here in performance. So he cannot control the bow at the frog, particularly when he plays off the string. When he's playing on the string, he can control it. But when he's playing off the string, he cannot. Now, what do we know about this very bizarre condition, musicians' focal task specific dystonia? A lot of what we know comes from the work that Eckhard Altenmuller and Hans Christian Jabisch and others have done in Hanover, where they have an Institute for Music and Medicine, and others have contributed large case series, including our group. Michael Charnas, Dick Letterman, Alice Brandfund-Brother, and others. But we know now that the age of initiating training affects the incidence of the disorder, that somehow starting before the age of 10 turns out to be protective. Further, the hands subjected to the greater technical burden seems to be preferentially affected. So that's the right hand in pianists and guitarists and the left hand in string players. For reasons we do not understand, focal tacitic dystonia in musicians is very different from any other form of focal dystonia, like blepharospasm, cervical dystonia, spasmodic dysphonia, etc., where more women are affected than men. Here it's 4-to-1 male to female, and that's not a reflection of the number of men going into music. In fact, there are more women going into music, but there's a marked gender predisposition for men. Certain instruments as well are preferentially affected, piano, violin, and guitar in particular. And as I'm going to show you, the pattern of the dystonia can be related to the mechanical demands of playing. We know anecdotally, and when we see these patients, that peripheral trauma and changes in instrumental demands can trigger the dystonia, and that this is not really a rare disorder. The incidence of torticollis is about 30 per 100,000. But if you look in the highly selected population of musicians, people who have decided to devote their professional lives to music and performance, this is a disorder that can occur as often as 1 in 200 times. And that's been shown in series from Brazil, from the United States, and from the Far East as well. So this tabla player has dystonia of the right index finger.
If I went slower, I could keep it straight.
If I have complete mobility.
This guitarist has affected 4th and 5th fingers of his left hand. So when he plays, those fingers extend off of the fretboard involuntarily. He is able to play passages using the first, the index finger, middle finger, and the 4th finger, but when he uses the 5th, they extend out. This can affect the wrist. This is a drummer who every time he picks up the stick, he develops tension in that wrist. So he loses the automatic rebound that is so vital to drumming. This can affect the proximal arm. This is a violin.
Yeah.
Here, fine. Then I have the trouble with actually getting the.
Every time he takes an up bow, the arm elevates involuntarily, just on the up bow. And this is a rock drummer, and he has involvement of the entire arm.
What about, so when you're playing with a larger hit, is that harder?
That's when it really kicks in. Because I need to be able to go like this, but I don't want to go out here, but it wants to go out there.
So you can see that any part of the hand, the arm, or the shoulder girdle, or all of it, can be affected by this disorder. So as we said before, the hand engaged in the more complex motor task seems to be preferentially affected.
Yes. You know, it's not normal.
Yep.
So then.
So that pianist that you've just seen here, he has focal tacitic dystonia affecting his 3rd, 4th, and 5th fingers when he plays. And like many, if not the most keyboard players, it's his right hand which is affected. Okay. Similarly, in plucked instrumentalists, you'll see this banjo player, a right index finger is affected. Now, in string instrumentalists, it's much more common to see the left hand affected, as you'll see in the 4th finger of this violinist that is pulling in as she plays.
Now it's starting to feel weird. Okay.
And you go higher.
It wants to go
It's
down.
going in. And among the woodwind instrumentalists, it's usually split evenly between the hands, except for the flute, where the demands of holding the instrument with the left hand likely increase the number of patients we see who have it in the left hand, as you'll see in the fourth and fifth fingers of this instrumentalist. So, the hand that has the greater demand does seem to be more preferentially affected. Now, that doesn't mean that the entire hand is equally affected. In fact, the ulnar hand, what we call the power hand, we'll talk about that in a minute, is preferentially affected. So you see 3 and 4 or 4 and 5, or the combination of them, much, much more commonly than you do first and second finger. That doesn't mean that you don't see thumb and index finger, as in this gentleman who built a combined guitar banjo, and he has a problem controlling his thumb and his index finger when he plays it. But the 3-4-5 pattern that we've already seen before is much more common.
Sometimes it does that. You see that third? Shouldn't do that. It should be like.
All right, so the question is why? Now, before we show this, Napier in the mid-20th century put forth a very interesting and I think powerful idea that we think of the hand as one entity, but really our hands are two mechanisms. One is the precision grip, which we use through median innervated muscles to grasp objects, and this is what surgeons rely on for their careers. The other is the power grip, which uses the ulnar part of the hand to exert force on an implement. And the task determines the grip, so that when you put in a light bulb, you first get purchase with your median grip, and then you power it in with your ulnar grip. Now, how did the hand develop? Back when we could go to the zoo, as I did in the mid-2000s here, you can see about 60 million years of evolution over primates. And then what does that tell us about what happened in the last 400 years of musical revolution in terms of the development of classical music? So here are our ancestors, music Camerons, and they have a fairly primitive hand. This is a foot hand. It grasps and it opens and closes and doesn't really have specialization of the hand. It presents food very well and hangs on. They are about 60 million years removed from us. When we get to the gibbons, they're now 30 million years removed from us, and they have the beginnings of a specialized hand. Their index finger is markedly elongated, likely for grooming, which is a very important social activity. They spend much of the day doing this, and they do it very eloquently. So the hand is beginning to be specialized in this manner. By the time we get to gelada baboons, which are about 15 million years separate from us, we're beginning to see use of the hand in adduction of the thumb and marked grooming ability. But it's only really when we get to the great apes, the gorillas, the chimps, and the orangutans, that we see true specialization of the precision grip, the ability to oppose the thumb and the index finger in the volar surfaces to get true opposition and control, which allows the animals to do very delicate things. For example, pulling off an individual leaf to eat. And this we see in the wild as well. And Jane Goodall observed this in her primate. This is an orangutan. He's showing you, David Attenborough is showing you this orang mom using the power grip. She learned this by watching, and she uses it to saw. That's the ulnar grip, the power grip here that's involved. But in the wild, one sees the precision grip. So These are Jane Goodall's chimps, and they are fishing for termites with the tools that they make. And then they strip them of the termites to see that. These are the Kyoto chimps. This isn't designed to show their motor performance, but it is quite remarkable. So they can do this. They learn how to do this very effectively. And in fact, they're much better at it than we are. So a year later, they can take the whole scene in 150 milliseconds. You can't do this. We fail miserably. So what does this mean in terms of how the hand developed? Well, in the wild, we developed this precise grip for using tools and for survival. But music didn't think about the hand. Music just thought about music. And so the instruments that we have designed that you'll see here put equal burdens on the four fingers besides the thumb. But the ulnar part of the hand, the power hand, was not designed to do all this. And we may have asked too much of it, which may reflect why we see so much dystonia affecting the ulnar grip. This is Emmanuel Feueron, arguably the greatest cello virtuoso who ever lived. And I hear. You get the idea. So we have also seen, in addition to the hand patients, a remarkable number of patients who develop focal Civic dystonia of the embouchure. So what is the embouchure? For those who played a woodwind or brass instrument, you are very familiar with this, but it's really the collection of muscles, both of the face, of the lips, and the tongue and the breathing apparatus that controls the flow of air into a mouthpiece. Here we have Miles Davis and John Coltrane. And it's more than just what's happening at the mouth. This is a process of controlling the airflow and the air column to produce the required resonance and diaphragmatic control, but also, of course, cortical and subcortical control of all of these complex structures. And it really is quite a subtle business, because what particularly brass players spend their lives doing is controlling the buzz of their lips. Now, we're familiar with the buzz because for our vocal cords, that's how we produce sound, by adducting our vocal folds together and producing a vibrating string here through which the airflow goes. But we don't see this ordinarily in brass players. This video has a brass player playing with a clear mouthpiece. You wouldn't see this with stroboscopic lights, so you can see in slow-mo this vibrating string here, which you're going to see produces the sound. As expected, when he goes up the octave, the string length goes in half and it goes twice as fast. But again, we don't see what else is going on until in 2015, Munich, colleagues figured out how to do very high-speed MRI with gating of the machine at about 30 pictures per second. And they put elite horn players into the machine and fixed up an MRI-compatible device where they could play, or sort of play, and they observed this. So you see this profound activation of all of the muscles, including the tongue, soft palate, and pharynx that produce the sound. Now, again, you wouldn't see any of that. All you see is the mouthpiece here, but it's really quite astonishing.
Blue talks in scary places.
So in the last 20 years or so, I've seen a remarkable number of these patients who've developed dystonia of the embouchure. And you're going to see some of these. I'm not going to obsess about the phenomenology, but it's very rich and very varied phenomenology. And the patients have a lot to teach us if we listen to what they say. It's the lower registers there.
It is, but right there, it gets better. Right,
And then it gets
down.
better,
yeah.
yeah. So this gentleman is a tuba player and his lips lock, but only when he goes slowly. So it's very velocity dependent.
And now a little slower.
Instrument specific, so he's able to play the flute quite well, but he doubles as a saxophone player. He cannot produce a sound because his jaw will not control the instrument and the airflow. It's a trumpet player with mej, with a big trip.
That doesn't work as well.
More secure there. Move it a little closer to the mouth.
It's not as good.
Not as good. It has to come from me.
So he said it best. It has to come from him. So you see all of the classic dystonic phenotypes in these forms of dystonia with sensory tricks, etc. What we've learned seeing these patients is that there is also, like in the hand patients, a relationship between the phenotype of the dystonia and the instrumental demands, so that the tremor phenotype or the lip pulling phenotype is much more common in high register instruments, which have a greater demand on the embouchure. And the lip lock phenotype that you saw in that tuba player is only really seen in the low brass register instruments. And jaw and tongue involvement is much more common in woodwind instrumentalists and often spreads to speech and eating. So this can be a real risk for these patients. So I want to shift gears here and talk about some more recent work that we've done. This is how I think of the mechanism behind musicians' dystonia. So as we've discussed, there's some underlying endophenotype in these patients due to their gender, due to their age at training, perhaps their biomechanics. And they go along their careers and something happens at some point. There's an environmental trigger or a trauma, and they end up in this dystonic prodrome. And if things don't go well, they fall into this, what we used to think of as totally permanent dystonic network, where every time they try to play the instrument, they encounter this horribly frustrating condition of focal test civic dystonia. And so what are we trying to do when we treat them, either with oral medications, botulinum toxin, even surgery, etc.? Well, we're trying, ideally, to push them back up and even back into the endophenotype, an idea that I would never have considered when I first started seeing these patients almost 25 years ago. But I'll show you two videos here which illustrate that perhaps we shouldn't be so sure that this is impossible. The first video is from my colleague Eckhard Altenmuller with a musician with hand dystonia. So you don't have to be a musician to realize what just happened there. And the two videos are taken only an hour apart. So this individual came to see Eckhart and had noted that when he used marijuana, his dystonia got much better. So Eckhart did an N of 1 blinded placebo-controlled trial and showed that in his case, the dystonia was sensitive to THC, something we do not see commonly. But essentially, he moved the dystonic network back almost completely to the end of phenotype. Do we ever see anything like this in clinical practice? Well, we've been injecting these patients, by we, I mean my colleagues, for quite a while now. And sometimes we see things that are hard to explain, as in this patient.
So that really brings.
He has dystonia, pretty severe, affecting his left index finger. He built a splint for himself, which doesn't really work well in parlance. Here he is 2 weeks after his injection.
In it. Well, it's better today.
You're having less curling with the object.
Yeah.
And here he is. 6 months later. He only got about 5 units to the left FDS of 2.5 units to the FDP. We know biologically the toxin is gone by this point, but the dystonia really didn't come back. And in fact, he saw me 5 years later and looked identical. How is this possible? And this is not a completely isolated occurrence. So in the last 6-7 years, when I was at Mount Sinai and then moved over here, collaborated with Dave Simpson using this remarkable molecule that we sort of take advantage of. But this is Alan Scott, the genius who developed this in a recent trip to Hanover 2 years ago with my colleague Glenn Esther. And when I first started seeing these patients, there was a lot of therapeutic nihilism for the use of toxin in musicians' dystonia. People had tried this in the 90s, even in the early 2000s, but that sort of changed by the mid-2000s with some publication. But what people used to say is that it's too complicated, the pattern of the dystonia. How do you know which muscles are the triggers? How do you avoid compensatory muscles? How do you account for individual variability of the sensitivity to the toxin? Often these patients are under the gun. They don't have 9 to 12 months to get better. They have to get better quicker. Of course, with musicians, particularly classical musicians, want to be perfect. And the goal of treatment, of 70% may not be good enough. And certainly anatomy is critically important, as we've learned. And in the last 10 years, I've become completely convinced that high-resolution ultrasound, which you see here from my colleague Pat Drummond, combined with E-stim, is very, very important for musicians. So this, you're looking at a cross-section of the forearm of FDS of the 4 digits, and the patient is now individually moving each one, and you can see each fascicle there moving. Here is moving the FDS of 2. And by using high-resolution ultrasound with the E-stim, here's the needle going in. Here you're going to see the E-stim just of 2. So if a musician has just involvement of the second finger, you do not want to inject the third. And you can even see the toxin entering. So we set out in 2014 to do a trial that had an unusual design in that was double-blind and placebo-controlled, but it had boosters, which was anathema at that time. We didn't use boosters because we were concerned about antibody generation, but we picked the incobotulinum toxin product and threw caution to the wind, if you will, and the patients got boosted at 2 weeks and then at 4 weeks, and then they either went from placebo into active arm or active into placebo, and David and I were blinded. And the examinations were videotaped. These were the 21 patients that went in. It took 7 years to do this study, and there were no significant AEs. 19 of 21 patients completed the trial. Most of the patients were men, and we're just now analyzing the data here, but it's been pretty apparent what happened when you look at the videos. But again, my colleagues, Alex Pentaliad and Eckhard Altenmuller, looked at all these videos, but they looked at them after I had edited them, and I edited them so that they were blinded, and I randomized them so that they did not know whether they were getting active or placebo or what the order was. and asked them to rate both the dystonia severity and the severity of overall musical performance. So this is, I think, subjecting it to as rigorous a goal as we could. We're taking out the effect of a placebo, we're taking out the effect of ordering, we're taking out the bias of the examiners who want the patients to do well. So I don't have time to go through all the statistics. We just analyzed statistics and submitted this as an abstract to the MDS. Surprisingly, the result was met statistical significance even with a sample size of 19. And I'm going to show you some of the videos. This is the most dramatic example, that tabla player you saw before. So he has flexion of that index finger, the most important finger actually for playing the tablas, in the right hand of the index finger. And he got injected here. We didn't know if it was active or placebo. It turned out to be active, just for the FDS and FDP of 2. So he was clearly quite a bit better, and he got a little bit of a booster here. And a little more. Here he felt he was normal, and then he went into the placebo arm. It actually takes quite a while for it to wear off. Here is almost the way he was before. You get the idea. This is another patient.
Because now, as you can see, the fingers want to curl down, and that delicate just rest your fingertips on the string thing is kind of not happening anymore. Because as soon as I put my fingers on there, they just press and they do this pulling down.
Right.
And so basically I can do like one finger.
So he had had dystonia for more than 20 years and was incapable of playing at all. So this was about as bad a dystonia as you're going to see in musicians. Here he is at his peak. So he's certainly not normal, but it was a very meaningful benefit for him. And we learned a number of lessons. I think what we learned is that this is too complex a disorder to try to get it right in one go. And the booster paradigm using these localization is probably critical to success. You see the benefits of the toxin on the dystonia well before you see weakness, which is interesting, since it may be that its effect on the gamma efferents is critically important in the benefit. And the duration of this benefit exceeds 3 months for reasons we don't fully understand. Now, once this artificial, protocol was out of place, we were able to actually take the patients out of it and continue their injections. This was our patient who actually was able to play a tabla concerto, believe it or not, with the New York Phil right before the lockdown, and it was very meaningful. We did not see much of a placebo effect. And you need to combine this with retraining approaches and ancillary therapies. These patients are quite resilient and motivated to participate in clinical trials. But the big impediment is actually insurance carrier approval. Probably more than half the patients that we would take care of don't have any insurance at all. Now I'm going to close with this brief video clip of Leon Fleischer from his Academy Award nominated short on his life, Two Hands, who really describes everything there is to know about the experience of a musician with dystonia.
Was preparing for the most important tour in my life. I had a minor accident. I was carrying a piece of garden furniture, one of these cheap chairs, slipped from my hand, cut my thumb. You know, after my healing period was over, I got back to practicing. And I noticed that things didn't feel quite right in my right arm. Bit by bit, fifth and fourth finger wanted to just kind of curl under. And this got progressively worse, progressively worse. Took about 10 months before the fingers just curled under totally and would not, or took the most enormous kind of effort to extend them, to keep them out. Couldn't play the piano that way. Every day I would test it. I would hold the hand this way, I'd hold it that way. I was trying everything. I was trying hypnotism. I wish I could remember them all.
Well, I wrote down a few, and perhaps you'll tell me. I've heard of the EST,
Yeah.
L-Dopa, myotherapy, hypnosis,
Right.
biofeedback, tiger balm, and then ultimately Scotch. if you can tell me what they are.
I've blocked all of that
Well,
shit out. I really have.
I
Today, even the fact that I am playing with two hands, I am a dystonic. I have dystonia, and there ain't no way of getting rid of it. There is a kind of inevitability in every great piece of music. That doesn't mean that that's the sole possible way of dealing with it. But potentially, that's what a great performance is. An inevitability, even with the greatest of surprises.
So Leon did more to promote the disorder than anyone. And in his honor, we have renamed the foundation we started 20 years ago, Musicians Dystonia. He passed away last year at the age of 92. So I'd be happy to take any questions from people who may have them. And thank you for inviting me to be with you.
Thank you, Stephen. This is Rich O'Brien. That was absolutely phenomenal. A comment from Janice Massey, who I don't think is on. She wrote, thank you so much. And Janice is an expert in single fiber EMG and Botox. And she pointed out that the single fiber EMG after Botox can be abnormal for several years or changed for several years, even without injections.
Yes, yes. I think the more I see, and I don't do limb injections. I do neck, jaw, hemifacial, and bleph. But you know, this is a very unusual and powerful molecule, and its mechanisms of action are not simple. As you can see, it's being studied in more than 200 indications. So there's a lot we don't know about it, particularly in this unusual condition.
So I invite anyone with a question, either put your name in the chat or your question, and we'll call on you. Yep, Jim Burke has the exact same question I was going to ask.
Right.
Do you see baseball pitchers with this?
You definitely see sports individuals. So there are well-known examples of pitchers who lost the plate and lost it in a big way. It's almost certainly dystonia. Chuck Knobloch probably had dystonia as well. We've seen this in shortstops. The yips is a little bit complicated. There is a subset of golfers who Charles Adler has shown using very elegant work with hand sensors and others who have involuntary activation, usually a pronation movement on putting. And it has all the features of dystonia. However, for every one of those, there's probably 10 golfers who have a anxiety state around putting that makes them think they have what we'd call the yips, but we wouldn't really classify that as focal dystonia.
And I've heard that CBD products are very commonly used by professional golfers just for that issue.
I mean, some very famous golfers, Ben Hogan had this, you know, then he started to putt using it, then they outlawed it. So.
Dr. Frucht, great presentation. I have a quick question as well. You know, you mentioned that this one musician who was able to go back almost to normal with THC, and it's really interesting to think about the network underlying it. Do you think the duration of the disease also has some role in the network stability of the dystonia, network?
Absolutely. Not only that, well, you know, first of all, with the internet and with the availability of patients to see others and their stories, it's much less common for us to see people who have very complex multi-finger and arm involvement now. And Eckhart also says that he's not seeing those patients anymore. They're diagnosed much sooner. You know, the idea that seeing the patients earlier and getting them into treatment earlier may be beneficial is not new. If you go back to Gowers and his descriptions of writer's cramp, he mentions that when he sees Scrivener's clerks, if they have had the disorder for a while, it is much less amenable to treatment. And I think that is true. When we see someone now who has an isolated finger or two adjacent fingers with flexion, believe it or not, I often now think to myself, I think we can handle this. I think this is handleable. When I see somebody who has multiple parts of the arm and has had it for a decade or all, I'm much less optimistic now.
Mm. And do you think the compensatory mechanism, which is also really fascinating, these people, well, one is the sensory trick that these people use, and it partially alleviates, but as we're thinking about therapy and developing more therapies, do you think we should be using the sensory trick to sort of build on it and maybe develop therapies that kind of amplify the sensory trick in some way?
I think, you know, the tricks that they may discover, the glove trick of wearing a glove and other things, these are tantalizing guides to how to reboot the network. And, you know, people have even, you know, Taira, as a surgeon in Japan, has published these enormous series of radiofrequency VOA thalamotomy in these patients with results that haven't been replicated elsewhere, but are nonetheless very interesting. You think, how could you possibly send a musician for this? But if you live to play, if this is who you are, some of these patients, believe it or not, are willing to take that risk. It is their identity. But you know, can we translate that sensory trick into a durable therapy? Personally, I think that's how toxin is working. I think it's a prolonged sensory trick. That's what I think.
Very interesting.
So I want to remind everyone again about the photo at 9:30 in the usual spot. There are no other questions, but I'll take the opportunity. So I think the real virtuosos now are the young folks who sit next to me and type 100 words a minute. What's dystonia like in that population?
Good question. So what's remarkable is that you don't see a lot of typist dystonia. What's even more remarkable is, to my knowledge, there is not a single case of chopstick dystonia that's ever been reported. And if you think how many billions of people use that, why isn't it reported? I think this is not just a curiosity. I think it reflects a fundamental aspect of the nature of task in motor learning, and that there are certain innate tasks that we learn probably with a more protected automatic pilot. But these artificial tasks that we've set up, playing these ridiculously complex instruments that require a decade or a decade and a half of concentrated effort for 4, 6, 8 hours a day, I don't think the nervous system was designed to do that. And I say that speaking as somebody who put in the 10,000 hours. So I think that not all tasks are equal.
Well, thank you so much. And Noreen, thank you for extending the invite. It's been thoroughly enjoyable.
Yeah. Well, thanks for having me, and I'll see you at noon.
Yeah, at noon.